Yeah, some of mine have transitions, so I'll when I say next slide, the slide won't actually change, but it'll be fine.
Okay.
We will be there now. How many people have we got waiting? Poor old Sudir's waiting.
They're all coming through, and the waiting room's off, so everybody will slowly just come in naturally, Dagny, with no
Brilliant.
beeping at you.
Brilliant.
Fabulous.
Good afternoon, everyone. We're just giving it a minute or two. It's a couple of minutes yet to midday before we formally start the session. If you are happy to, please do put your name and your role in the chat. And we'll kick off formally in a couple of minutes. Okay, good afternoon, everyone. I think we will make a start. It is bang on midday. A very, very warm welcome to all of you. My name is Dagny Rajsingham. I'm Deputy Chief Medical Officer at Guy's and St Thomas's and Medical Director for Secondary Care Transformation in NHS South East Region. Thank you to all the regional colleagues and non-regional colleagues who are joining. And I just wanted to say that I know that it is turbulent times. Many of you will have been on the briefing, but actually that maybe the timing of this session is even more pertinent because it is work like this. It is frailty, flow, and the left shift that we need to be focusing on in order to ensure the sustainability of our NHS. I'm going to hand over to John, who is CEO of the Institute of Health and Social Care Management, to do a brief introduction, and then we will get on with the session. John.
John,
you're on
mute. I can't believe I've done that after nearly 6 years of dealing with Teams and goodness knows what else. Big moment, and I blow it by being on mute. That's £10 in the charity box. Welcome, everybody. I'm absolutely thrilled for the Institute of Health and Social Care Management to be hosting this really rather important event. Dagny, you know, has done a splendid job and will be chairing as we go along. We have some stellar guests who are going to be presenting throughout this, and all I can offer is my unqualified support to everybody involved in the whole business of frailty, left shift and flow. I wish you all well. Thank you for your attendance today, and I'll hand straight back to Dagny. Thank you.
Thank you very much, John. Please could I ask people to use the chat, keep your comments, conversations, reflections. This isn't purely about listening and learning. It is also, I'm very, very keen that the collective wisdom of everyone on this call is captured. We will be recording the session, so it will be available. I'm going to hand over to Professor Jagdeep Desi. She's a colleague of mine at Guy's and St Thomas's, and even more importantly is president of the British Geriatric Society, and she's going to give us a short introduction to the national landscape and the left shift. Over to you, Jagdeep.
Thanks so much, Dagny, and thanks for the opportunity to speak to everybody today. As you say, very turbulent times at the moment, and a real need for us to be looking at all the things that we can do collectively to continue to have our sustainable NHS for the future. So I think as a geriatrician, if we do go to the next slide there, thank you. I think it's always really important for us to celebrate the successes of health and social care over the last 75 years or so, where we have seen our population pyramids now become population columns pretty much. With now kind of 1 in 5 people living above the age of 65 amongst our communities. And of course, in health and social care, we don't see everybody out there who are living full, well lives, enjoying all kinds of things. And I think it's really important to acknowledge that we only see, a proportion of older people. And there are lots of people doing all kinds of amazing things out there in our communities. If we go to the next slide. But of course, what we do know is that with aging comes health-related problems. And we know that about 10 years above the age of 65 are lived with health-related problems. And if we just click there again, and of course, that's not surprising, because if we look at the main pathological processes that kind of occur in our population, whether they're metabolic, degenerative, neoplastic, or cardiovascular, all of those processes happen increasingly with increasing age. So we see kind of all of these kinds of comorbidities happening more frequently as people get older. And if we go to the next slide. And of course, that means, and if you just click there again, thank you. What that means is that actually the population pyramids aren't so interesting to us in health and social care, but these other pyramids that show us what happens in health and social care are much more important. So you can see here with the table on the right that it's older people who present to our health and social care services. Of course, women of childbearing age and kind of babies and young children. But you can see actually we're now looking at a funnel when we look at the population pyramids presenting to health and social care. And that's really apparent in lots of the data when we compile all of the different reports, showing us that if we look at all of our people out there aged over 65, about 1 in 3 of them are on a waiting list for something, whether that's diagnostics, a medical intervention, or a surgical intervention. If we look at our front doors, then 40% of adults presenting to ED departments across the country are aged over 65. And 66% of our hospital beds are occupied by older people. The other really important thing there is that 1 in 7 of people who we do discharge from hospital actually are readmitted within 28 days. So there are things that we need to be thinking about for the population at the time of discharge to avoid that revolving door that's otherwise seen. And really importantly, with all of the kind of discussion at the moment, prompted by the Assisted Dying Bill, the End of Life Care Commission, we know that 1 in 3 people in hospital are in the last year of their lives, and we're spending £22 billion on that last year of life. So this is a really critical thing for us to be grasping if we're going to have a sustainable NHS for the future. Just click to the next slide. The issue with older people is, of course, it's not just the numbers. We know that increasing numbers are seen across the system, but this group comes with a lifetime of accumulated issues. So we know that a fit 80-year-old isn't the same as a fit 30-year-old because there is physiological change with aging. But then once we add in socioeconomic determinants of health, which account for at least 80% of people's health status, that, of course, has a greater impact over time. So smoking or alcohol dependency, poor housing, poor nutrition, all of those issues that can affect both health status and health-seeking behaviours. And then we have the issues around multiple long-term conditions and frailty, things that we're going to focus on in the next hour or so. And if we go to the next slide there. And so some of those issues are kind of really tell us kind of how our older population are living with complexity. So if we're looking at those wider determinants of health, about 1 in 5 people aged over 65 are living in poverty. We know that almost 3/4 are overweight or obese. And we've done really well with smoking, but still 1 in 12 people aged over 65 are smoking. And we've not been doing so well in terms of activity. So let alone trying to get people to exercise, around about half of our older population is physically inactive. That means less than 30 minutes of physical activity 3 times a week. And then we add in things like social isolation. We know that all of this results in inequalities, whether that's inequalities driven partly by socioeconomic status, by age, by multiple long-term conditions, by frailty, and that it's these groups of patients who do wait longer for intervention, and when they do receive treatment, have higher complication rates. And just click there again. And that's really even before we start to look at the issue of multiple long-term conditions, which Nigel is going to be speaking about a bit more in detail. But half of our older population are living with multiple long-term conditions. This kind of has all kinds of implications for that population. Not only are they being referred to multiple specialists and then patients having to navigate their way around different teams, arranging transport, arranging someone to go with them, but it also means that this group are more likely to have polypharmacy. So we know 3 in 10 older people take more than 8 regular medications. And we know that adverse drug reactions result in admissions and particularly in readmissions. So all of the issues that are raised by polypharmacy within this population who are living with multiple long-term conditions. And if we click there again, and then we've got these added other syndromes. So it only just becomes more complex. We start off with these socioeconomic issues, we start adding multiple long-term conditions, and then we have geriatric syndromes such as frailty, with a lot of older people living with this syndrome of frailty, which is calculated to cost around about almost £6 billion to the healthcare system. Adding in mental health issues, and then of course cognitive issues such as dementia, which is becoming an increasing issue for our population. And so much of that cognitive impairment being unrecognized in this population because we put it down to being part of normal aging and don't do objective assessments to be able to understand the scope of the issue. And if we click to the next slide, we know that this group, not surprisingly, then has worse outcomes, whether those are clinician reported, patient reported, or process related. And we see that at hospital level data, where hospital acquired complications occur most frequently in this population living with complexity. But we also see that in national audit data presented by HQIP and through inspections such as the CQC inspections, and of course with complaints and coroners that get picked up by our ombudsman. And if we click to the next slide. So it's clear that we do need to have a system level approach to support older people. And really we've got to get it right for older people if we're going to get it right for the NHS, considering they are the biggest user group of health and social care. So we do need to support our population now, starting with the life course kind of approach to it, to ensure that we future-proof the health and social care sector for tomorrow's older people. And that's where the primary prevention work really comes into play. But then at the same time, we do need to rise to the challenge of supporting older people to live well now by addressing the needs that they have through proactive or anticipatory care. Kind of, in some ways we could call that the secondary prevention part of our work. And a lot of this work's being done through the British Geriatric Society, and I've just illustrated that with a couple of reports there at the bottom. And the next slide. So that primary prevention work is going to kind of be looking at those shared risk factors for multiple long-term conditions and frailty, the things that we know a lot about already. And we don't need much more evidence to tell us that these are the things that we need to be focusing on. But what this does require is a policy change, not only at health level, but also at education, housing, work and pensions. And those are the kinds of initiatives that we've been working with the Faculty of Public Health and with Chris Whitty in the Chief Medical Officer's office to be looking at those aspects. And then to the next slide. Leading us on to secondary prevention, and particularly of frailty, but also of multiple long-term conditions. And of course, it's really important to be proactively identifying frailty so that we can put in proactive measures to avoid progression, to avoid crisis presentation, make sure we're delivering care in the right place, and that that's supported through a personalised care approach with embedded shared decision-making. And Lucy will be talking a bit more about this later. Go to the next slide. I think the important thing here is actually we've got so many of the resources between us all, and certainly we've tried to collate a lot of these at the British Geriatric Society website through the Frailty Hub and other resources as well through GSTT and NHS England. And there's been lots of work at kind of designing our kind of vision for the future, the strategy that needs to be undertaken. But at the same time, we now need to start to implement this. And this is what we'll be talking about shortly. If we go to the next slide. There is still lots of variation. And again, that's where the GSTT data really helps us to be able to work out where we're at locally by looking at some of those outcomes. Clearly, we need to make sure we have co-production with our patients and the public in designing these services, but actually all of those studies so far tell us the same things. And these are some of the things that I've listed here that we repeatedly hear when we're doing co-production work. So I think we do need to move on now from asking people what they want to actually starting to deliver it together with them. And moving to the next slide. So what's needed? Well, I think we do need leadership, and that's why it's so great to have this webinar. We need to be developing policy that's attuned to the needs of today's healthcare users, which is really different to when the NHS was set up, when we had a single condition or a single organ approach. That needs to lead on to commissioning of patient-centered services rather than condition-specific approaches. We need to look at some really radical disruption across boundaries. And again, Tanya and Lucy, I'm sure, will be illustrating that. We've got to adapt our workforce to support people who are living with complexity and be looking at that cross-boundary working, which requires integration across health and social care. And that also needs to be underpinned by supporting our public to understand as well what's needed when you're living with complexity. We need to address what matters to them, but that does have to be through evidence-based and cost-effective initiatives. And then the last slide, I think, which kind of is just a kind of little plug again for the British Geriatric Society, where we have been working really hard across organisations, certainly at the Department of Health, with NHS England, Scotland, Wales, Northern Ireland, looking at the workforce approach, but also with measurement and regulation bodies to make sure that we are measuring the right things that help us to be able to then deliver services that are required. So that's a little bit of the background around kind of where we're seeing things on a general kind of basis. I'm happy to take any questions, but or Dagny, if we want to take questions after the next presentations, then that's fine too.
We have time for maybe one or two questions. If you want to just pop your hand up, and Jade and Julie, if you don't mind keeping an eye. Whilst people are thinking, Jeff Berg did put something in the chat saying that unfortunately we're seeing a disinvestment in the NHS commissioning of VC voluntary sector and a de-emphasis in terms of proactive and preventative measures. So really a very important comment, Jeff, and I think I put that, I agree, and I think Jagdeep probably does as well. Could we come to you, Olivia, for your question?
Yeah, certainly. Thank you. Apologies for joining late. I'm Olivia Clymer. I'm Director of Strategy and Partnership at Oxford University Hospitals, but I confess that I was the Chief Exec for Health Watches in Central London for 5 years. So I would just want to echo what you've been presenting on and that need for co-production and the value in communicating to our patients and the families around them to understand this. And I think we did some work on long-term conditions when I was at Healthwatch, and very much about, you are not a series of conditions, you are a whole person, and empowering our community to be able to support and do that and be active participants in their care. So I just wanted to echo it and thank you for the presentation. Thank you.
Thank you, Olivia. Jeff, did you want to come in?
Yeah, please. Thanks for that, Jagdeep. Just wondered if you could say a bit more about capacity within primary care and community services. I know we've got great examples of geriatricians working in the southeast in London, but obviously an area we want to expand on.
Yeah, and I think that's so important, Jeff. This is a collaborative approach that's required, isn't it? And just yesterday we had a meeting with the RCGP to start to look at how we can support general practice colleagues to be able to identify people living with complexity using population level data, to then ensure that we're aligning the right team to the right individual. And I think some of that will come out in Lucy and Tanya's presentation as well, is around kind of how we start to segment the population, much in the way that we've done in the surgical setting. We've got the high volume, low complexity group of patients who go through the surgical hubs, and then we've got the higher complex kind of but lower volume group that you want to really be having a focused approach to. And this is a similar kind of approach that we can take here around how we use population level data, segment the population, but of course that then requires upskilling of teams to be able to deliver that. And hopefully that's going to, depending on what happens with the NHS England's kind of work and everything else that's going on at the moment, maybe the integrated neighbourhood teams approach may be the way in which we can coalesce some of this work. And then there's potentially a Frailty collaborative kind of piece of work coming from NHS England too. So it's just at the moment how we align all of these pieces of work, which there's lots going on, but we need to have a consistent approach between all of us to ensure that those messages are getting heard appropriately by the policymakers and then commissioned, not decommissioned, as you've rightly said there.
Thank you very much, Jagdeep. I'm going to come to John, but just want to reiterate that point, Jagdeep. There is so much that happens that is excellent and really good across the NHS. Us coalescing and therefore maximising impact is maybe where sometimes we miss a trick. So again, my thanks to IHSCM for allowing us to breach one of those boundaries between South East London and South East of England. John, your question.
Thank you, Dagny. I'm just conscious of the fact how few of our colleagues from social care are on the call today. Quite understandably, a lot of NHS people, but it strikes me that this collaboration between social care providers and health, if we can call it that, is just critical to this. And I wonder whether you have any sort of quick wins that from a BGS perspective, you'd be advocating we embrace.
So John, it's a kind of perennial kind of discussion, isn't it, around kind of people. So essentially, I don't think that we can disentangle health and social care when it comes to older people. One causes the other causes the other. We have to bring the two things together to be able to effectively support people to live well in their communities, avoid unnecessary hospital admissions, but ensure access to hospital treatment when it's necessary. So we have to bring the two together. So we're doing some work with 5 ICBs from the British Geriatric Society dotted around the country to start to share their vision documents, their strategy documents, but also the resources that they've developed to implement this into clinical social care practice. And that's got to be our route really at the moment, doesn't it, for kind of bringing together health and social care. We don't have a mechanism other than the ICBs at the moment. And I think Tanya and Lucy will be discussing some of those boundaries and how we can overcome them. So there will be stuff coming from the BGS this summer. We're hopefully going to develop a resource pack for ICBs that can then be shared. And of course, we'll share that with you for wider dissemination too. Or you're on mute, Dagny.
Sorry, thank you, Jagdeep. And just one other comment in the chat around standardising templates, really care plan templates, which you might want to type into the chat. There was just a question for that. Thank you very, very much. I am going to move on to Tanya Kelsey, who works within South East London System, who's going to give us what we've sort of done the national perspective, and we're going to hone in down now on a system, so ICB type system, and then we'll have some time for some questions. Over to you, Tanya.
Thank you. So yes, I'm Tanya Kelsey. I'm also a geriatrician in London, and I am the Ageing Well lead in South East London. So yeah, I'm going to talk to you a little bit about how we've started to try and implement all this change that's occurring at the centre in South East London. Next slide. Next slide. Great. So as Jagdeep alluded to, this is a really busy space at the moment with massive amounts of work done by parallel different groups. So you have to keep yourself very, very connected into these parallel pieces of work, because otherwise you come up with 5, 6 different plans which don't align. And in South East London, we're right this minute putting together our vision and framework for ageing well across South East London. In South East London, we have a sort of devolved approach. So each of the 6 boroughs actually are able to implement in their own ways. And that has some ability then to nuance to different populations, but also can make some challenges about having some common ground around what's the end game we're trying to deliver. So for South East London, we've been putting together a vision and framework for all the boroughs to align in terms of where we're trying to get to and how do we measure success that we've got there, and trying to think a little bit more around frailty at the population level and looking at what's success for mild, moderate and severe frail people, because clearly your outcome goals may be rather different. There are pieces of work going on, continuously around integrated neighbourhood teams, and clearly ageing well frameworks are in many ways the integrated neighbourhood team at its most complex. Long-term conditions clearly are common in old people with frailty, but they also need to create some frameworks without frailty for those in the younger groups. And the last thing we're trying to align towards is we're trying to move a little bit more towards population level outcomes and reducing some of those inequities that we see. And that can be quite an uncomfortable shift for clinicians, where focuses are often around one individual patient, and sometimes we may sacrifice the perfectionism for one patient in order to do good for more people. Next slide. This I thought was a really useful image from the National Associations of Primary Care, thinking about the INTs and the different parts that are important, and older people being one of probably the 4 big areas for INT development. As I alluded to before in the last slide, I think for frailty, it's about segmenting the population into groups so that you can target the right interventions with the right people for their particular outcomes. And that's whether they are severely frail, which may be the smallest cohort, but are the most those that use most health and social care resource, the moderate frailty group where there's perhaps some scope for rehabilitation and prevention of progression, the mild frailty group where really has perhaps been neglected so far in traditional services, and where this is really with a preventative space and how we can prevent people becoming more frail too early. And also the fit and well population, which would lend itself to some blending with work that are targeting working age adults and preventing them becoming frailer when they're in post-retirement. Next slide. So what are we trying to cover within a framework that brings boroughs who are doing things slightly differently? Well, one is coming together with a clear vision, but also we're trying to not be just inclusive of health. I think we've just alluded to it clearly that we need to work much more closely with social care, but actually it's not just about social care, it's about the voluntary care sector. big issues with housing, fuel and food poverty, community access to activities and engagement. And actually, we're bringing a lot more focus around how do you activate and increase your community assets, as well as being better sighted of your community assets, so you can really get communities working well for themselves, because the health and the social care bit really doesn't matter if the rest of it isn't working. We're taking a population level approach to targeted interventions, so right outcomes for the right cohorts. Your target for severe frailty is entirely different to that for mild frailty. Outcome measures, I think often because of the system measures that we have available to us, are often telling us outcomes such as length of stay or reducing hospital admissions and so forth. These are really important because we need to deliver value-based care. However, we need to find better ways of tracking resident level outcomes, population level outcomes, and outcomes for our workforce who are tired and exhausted and need to now try and evolve in a change process to enable to work differently, to deliver more in a different way. And that's quite difficult in a workforce that's quite exhausted. Next slide. We also want to find very good ways of dividing mild, moderate and severe frailty, and we're realising quite quickly that actually to find the mild preventative space is really very hard, and actually we need to work hand in hand with researchers to develop the right tools to identify those groups. And some of the way in which systems and ICSs can make themselves more sophisticated is creating that collective energy with their local research teams. I think we've identified that there will be key enablers, education clearly being a very important thing across the system in frailty specific training. I think we've spent probably the last 20 years developing multiple liaison services for geriatricians in various spaces, in the ED, in surgery, in oncology, in anywhere you can think of, in the medical wards, in the community. But actually we need to create a much bigger upskilling of the generic workforce to deliver the basic frailty care so that geriatricians can focus on the super complex. And that includes workers across all organisations. This is not just about health workers, this is about domiciliary care workers, this is about opticians, this is about your dentist, this is about care home workers, this is people in the VCS. So actually we need to come together as a system to align and work out what are the core elements of frailty we'll want a system to understand, and how do we deliver it in a robust way. Research I've mentioned. And then lastly, looking at digital and technology, as although we have a lot of different electronic systems nowadays, it's still clunky to align together, but also this group is rather more difficult to reach through digital methods. And whilst we need to align towards digitalization, we do need to think about digital inequalities and whether this may make it even harder for the most deprived in society to access, so mitigating against digital inequity. So next slide. I won't go through this in detail, but we have a plan of action on how we can try and realise an ageing well framework through a series of workshops and stakeholder engagements, coming together with an aligned multi-system ageing well framework for South East London, which will then allow boroughs to map their current activity and where they need to make more progress. Next slide. I think it's really just to highlight there are different spaces we need to address, 1 and 2 being the much more preventative end of the spectrum, where we really need to ramp up activity whilst trying to manage that really very busy space of the peri-hospital interface in hospital at home services and virtual wards and intermediate rehab, as well as in hospitals. That's a difficult challenge for the NHS when you're really firefighting in zones 3 and 4, but unless we start putting our energy into zone 1 and 2, we're not creating a different future for ourselves. In fact, the future will become rather bleak indeed. Next slide. So we've been trying to align against the BGS blueprint. So looking at the way in which you can manage some of the recommendations of the blueprints around severe frailty and about how you deliver compassionate, coordinated care near the end of life, how you deliver enhanced health in care homes, as well as actually thinking about other areas such as sheltered and extra sheltered accommodation, who perhaps the complexity more aligns to care home residents than domiciliary dwellers. How we design things around the interface for acute support and bringing that much closer to your proactive care space, so that rather than people stepping off cliff edges into different zones of care, actually you have seamless additions of bolt-on services that can be accessed as required. And then lastly, looking at population level education and how do you empower residents to self-manage. Things like strength and balance training and management of pelvic floor should be a standard public health message rather than something saved for clinical interventions once it becomes too problematic. Next slide. I'm just going to give you a real whistle-stop tour about some of the fantastic work going on in South East London and how people are trying to solve some of these issues at a place level, at a borough level. This is Lewisham and Greenwich targeting the severe and moderate frailty end, and they're looking at how they develop their service, the PAWS service. So anyone who likes cats will love this. And actually, you know, they're targeting these people and making really good outcomes and reducing hospitalisation, outpatient appointments, reducing length of stay, and doing really super work. Next slide. This is the Greenwich Frailty team, similar model, built in the community, has a core frailty team using what they call case managers, who are multiple disciplines of frailty practitioners who retain their core elements of who they are, whether an occupational therapist, physiotherapist, etc., working with multidisciplinary team across different organisations, and again with similar outcomes to the Lewisham model. Next slide. This is in Lambeth and Southwark, where I work, and we're taking a whole frailty system approach, looking at how you can in-reach into existing structures such as GP practices, using data sets to manage your population into risk groups, and then put in the right level of support. So frailty team support around moderate and severe frailty, and psychosocial model and long-term condition work and mild frailty, but really recognising that actually some of the core work we need to do in influencing communities and managing loneliness. We're also trying to do a big focus around health inequalities by doing outreach work into specific vulnerable groups, as well as making every contact count in other settings such as housing, the faith setting, acute interfaces, as well as social care. Next slide. This is Bexley, and they've been doing a fantastic data-driven approach, looking at what are the specific needs of Bexley that are different to the other boroughs, and they are now focusing on their moderately severe cohort as their core target of where the greatest impact may be in the first instance. Next slide. And lastly, this is Bromley, and they're perhaps been the most developed of the INTs in terms of having this community MDM structure since 2017. And again, this has had a great impact on the management of moderately and severely frail older people. Next and last slide. So really what we're trying to do in South East London is pull together all these fantastic pieces of work across boroughs. And I think where we're broadly agreeing, and I think perhaps most would agree, that really we're trying to find ways to deliver person-centred holistic care, identifying people using data sets for risk groups so you can target resources and interventions most appropriately, as well as target the way in which you prioritise tackling this problem. Improve access to resources and joining up and building resources in your communities where it's not sufficient. And as well as creating the environment for change with education, for opportunities for research to build the answer to the questions that you really don't understand yet. And lastly, trying to look at what are the common languages we can use across the system for frail older people, because what we might mean in health may be rather different to a social worker, a voluntary care sector worker, or someone else. So can we create common language so that we're able to communicate and work together more better? And finally, I think some of this is about us understanding that we have some cross-cutting skills across different disciplines, across different types of practitioners, and can we as a system work out what those cross-cutting skills are so that we can create those savings and have increased trust regardless of which organisation that we work, that we trust each other to deliver the right care with those skill sets. I'll end there. I may have gone over a little.
Brilliant. Not to worry. Thank you so much, Tanya. We will have time for questions for Tanya and our next speaker. So I'm delighted to introduce you to Dr. Lucy Abbott, who is now, we've just going back to the structure of the session. We've had the whole country's landscape, and then we've come down to a system strategic view, and we're now going to actually implementing frailty and flow. So I'm going to hand over to you, Lucy, and you will have time for questions for both Lucy and Tanya at the end of Lucy's bit. Thank you.
Lovely. Thank you very much. So yeah, I'm Dr. Lucy Abbott. I'm also a consultant geriatrician. I chair the Frimley Integrated Care System Frailty Network, and I'm also our NHSE South East Region Clinical Advisor for Frailty. So I support trusts and systems across the region with their frailty work. Next slide. So really just going to share today what we have been doing within the Frimley ICS, and we very much right from the beginning. So we started this journey back in 2017, where we've been consistently taking a system approach to frailty, focusing on both proactive care for people living with frailty and reactive care, and also our care home population as well. So I'm going to share some examples of the work we've been doing there, and also finish up with a bit of key learning. Next slide. So this slide essentially shows our vision for people living with frailty across the Frimley system. And essentially, it's exactly what you've already heard about a personalised, holistic approach, recognising that someone living with frailty actually wants to and will hopefully spend the majority of their time living in their usual place of residence. And essentially, we need to have the system leadership and that system oversight, bringing together all of the partners that we need in order to provide that integrated holistic care. And ultimately, we want to provide the right care at the right place, at the right time, by the right person. And essentially, we want to take that proactive approach of keeping people living well. So things that we have in that space at the moment. So of course, as we've already mentioned, it can't be too health focused. You know, we've got social care, we've got voluntary sector, etc. We have a remote monitoring program I'm not going to talk about, but again, that's about monitoring people who are high risk, trying to predict and early deterioration and get in early. We have integrated care teams, that multidisciplinary teams again that will support individuals, and we have geriatricians in reaching into those. And of course, we have our primary and community care and everything that we have set up to support care homes as well. Unfortunately, we all know that it doesn't take much. A minor insult, such as a simple infection or a breakdown in someone's care and support network, can precipitate a frailty crisis, which can then precipitate that 999 call or the need for some kind of emergency health response. And that's when we need to provide a good reactive model of care. So we are hoping that this will be access through a single point of access, and that can be used by GPs, social care, community services, etc. And then that comes through to our urgent community response, hospital at home service. That interfaces with the acute hospital and the front door frailty team and the frailty SDEC. And then, of course, there's a really important role for intermediate care and community rehabilitation once people have received their acute care. So that's the kind of overall model. Next slide. And We know that this model must be working, so it's difficult to know which bit of the model has the most impact, but essentially if you track our frailty data in terms of people that are admitted to Frimley Park Hospital. So you can see, looking at the time, that there was a significant drop during the COVID pandemic. So we knew that fewer older people were coming to hospital at that point. And the other strange dip is when we launched our electronic patient record EPIC, because we had some problems with our data reporting at that time. But otherwise, you can see that the trend is either flat, and in fact, over the summer looked as if perhaps it's almost coming down as well. Whereas with population aging and population growth, we would be expecting that our admissions would be increasing. So we think that by trying to do that left shift and that model of care, that we are having an impact on usage of acute hospital services. Next slide. So in terms of our proactive approach, it sounds very similar actually to the work that is already being done in South East London as well. So essentially we have a shared care record, which means that we use the John Hopkins tool to proactively identify people with frailty who are at high risk of admission. And that means that, so we can generate lists for our community frailty services, and essentially they can give those people a call and say hello, and people do not like the term frailty, so we say hello, would you like an assessment in order to keep you living well, is how we phrase it. That person then actually has a face-to-face assessment, because we need to make sure that they're suitable for the proactive care programme, and then they go on to have a holistic assessment based on comprehensive geriatric assessment, and that's the tool we know that improves outcomes for older people with frailty. We then do that personalised support planning and interventions to keep them living well, including something called the respect form, which gives recommendations about emergency care if that person were to fall into crisis. And essentially we coordinate the interventions and the support that's required. And the outcomes that we found from that model of care is that if you look at people's A&E activities and admissions before and after the proactive interventions, we've managed to reduce it by 30% for that cohort of people. And of course, polypharmacy review is a really important part of those proactive interventions, which can actually result in real financial savings. In the interest of time, I'm going to skip through the next few slides because there's some more detail there about what the model actually looks like if you want to read about it. So then when someone falls into a frailty crisis, we then have an urgent community response and hospital at home service that can respond to people in crisis. If we go on to the next slide. Yes, this is just some, as you can imagine, the patients are very grateful for the proactive care that they receive. Yeah. And essentially hospital at home is about bringing that acute level care to the patient's home when they fall into frailty crisis and become unwell. And essentially we've got lots of kit that we take with us, so point of care testing, we can get blood results, we can do ECGs, we've got a bladder scanner, we can give oxygen, we can give nebulizers. And essentially we use our electronic patient records in order to be able to document and to order tests, investigations, prescribe, and that enables us to kind of communicate across the acute and community boundaries. Next slide. If we go on again, there's just some more details about what we can offer. The critical thing is that the hospital at home service can be accessed by any number of referrers. So we'll take referrals from 999, GPs, community services, etc., which means that we can rapidly get to that person within 2 hours. And we work very closely with our ambulance provider, and this means that actually we may even go and respond to a patient before the ambulance crew has been dispatched. So we're also helping to take the pressure off the ambulance service, as well as primary care colleagues, etc. And again, there's just some outcomes here about showing actually how effective the service is. So people, as you can imagine, absolutely love the service. They're at home, they get better quicker with their supported by their relatives and their normal carers. And the other thing is that staff find it very satisfying to work in these services because it's a really good model of care. Next slide. And again, this just proves sort of how many patients we're seeing and that we do actually genuinely keep people out of hospital, because I think there's some challenge about virtual wards as to whether perhaps you see people for a short time and then they end up in hospital anyway. But this shows that we do, with appropriate escalation planning, appropriate care and treatment, that we are able to keep people out of hospital. Next slide. Next slide. And then just a couple, and again, as I say, we get fantastic patient feedback. If we go on to the next slide. So yeah, just a couple of things about care homes. So again, we have a really robust care home support model within the system. So this is led from system level, but also with community services and primary care as well. And essentially we do a lot of education with our care homes. We have a regular care homes forum, and things that we focused on recently: oral care, nutrition, falls, delirium, dementia, recognising end of life, and the Restored 2 tool as well. We've made sure that all of our care homes have NHS email addresses so that they can communicate easily with the GPs. And of course, we now have the weekly care home ward rounds as well. The remote monitoring I've already mentioned. And then again, we've been using the respect form to make sure that residents have clear escalation plans, and that ideally they receive that hospital at home urgent community response in the first instance, rather than needing to come to hospital. And if they do need to come to hospital, then we've got our acute frailty service at the front door in order to get them back to their care home as quickly as possible. Next slide. And this is just to show that we've been tracking some of our care home data. And again, this gives you data from this winter. So you would be anticipating people would be sicker over the winter period. We'd be seeing more 999 calls, more ED attendances and admissions. And in fact, we haven't been seeing that over this winter, which suggests that we are able to provide that community-based approach instead. And again, just the next couple of slides just show some of the care homes data that we've been able to track, and we will be taking forward, because, for example, I've blocked out the names for IG, but we know exactly, you can see on the box on the far right there, we know how many beds the care homes have, and then we can also see how many 999 calls, how many ED attendances we're getting from each care home, and then we can actually do some specific work to kind of support the residents in those care homes as required. So in terms of our key learning, if we just go on to the final slide, really the key to all of this, to sort of the achievements that we've made, is taking that whole system approach. So no one provider can do this in isolation. It's about working together and having a very wide network of stakeholders at our Frailty group, from public health through to the acute trust. Obviously, people have mentioned that there's loads of kind of national policy from NHS England and guidance from the BGS, so making sure that we've been using that to really inform the services. And obviously there isn't lots more money, there's not lots more people, workforce, but by collaborating, integrating and avoiding duplication, we're managing to kind of do things with actually very limited resource. Having a shared care record and digital integration across our community services and primary care have been really critical to supporting this. And ultimately, we need to make sure that our workforce has received appropriate sort of training and education to deliver this model of care. So it's a bit of a whistle-stop tour of the Frimley system, but that gives you a bit of an idea of what we've been doing.
Thank you so much, Lucy. So you've had the national landscape, you've had a system overview with strategy and pulling together the key and important actors, and then you've had an example of implementation in Frimley with the evidence base around its value. So I'm sure there are questions for either Tanya, Lucy, or for both of them. So I'll open it up now. John.
Thank you, Dagny. Question for Lucy, if I may. I was fascinated in the frailty assessments that you offer to people when you're worried about them or there's cause for concern. I just wonder how you manage the reaction that you get from either individuals or families to this suggestion that they may be deteriorating.
Yeah, and that's why. So when we when we started off, we rather naively did phone them and say, would you like a frailty assessment? And that didn't mean anything to people, and they didn't like the term at all, which is why we then phone and we said, would you like an assessment to keep you living well? Because actually, or keep you independent, because that's actually what matters to people. And the other thing is that we are effectively cold calling people from a list. And there is some clinical validation that obviously happens before we phone them, but it is possible that that person, that how they appear from the coding on the electronic record, it isn't, then doesn't actually correlate with the actual person, so because it's not 100%. So that's what we talk about, keeping people living well, keeping people independent, and that does mean things to people. We do have a few people that think it's a spam call, that it's some kind of scam. So again, often, so the people who make those initial calls, we give them a number and then we say, if you want to phone us back and it is the primary care network or whatever, please do. And just to prove that we are we are who we are, we've got everything up on the website, so we can point people in that direction. We've got a patient leaflet as well that we can send out. But there's a little bit of learning, and that's something that I would share if anyone was setting this up, about how you do kind of proactively approach people sort of to get them engaged in this. But once they've had the assessment, and then they tell their friends, and so on and so forth. So yeah.
Thank you, Lucy. And Christopher, would you like to ask a question?
Hi, Christopher Tibbs, Regional Medical Director South East. It's really a comment. As many of you know, I looked after my 102-year-old father until he died in October. And although we didn't have the benefit of the Frimley Frailty Service, we had the one from Royal Surrey. And I think it is very interesting to reflect how important it is to break the mold of grandpa's ill, let's take him to hospital, and to make sure that in advertising all the excellent work that you do, Lucy, and the other frailty services around the South East, that we don't overload the system. And I wondered if you felt that you have enough resource put into your service to be able to really work at keeping patients at home. And this, of course, is in the context of all the news about shrinking the NHS and making it more efficient, because I do genuinely believe that this is one of the ways that we can make a massive impact on resource expenditure. And I just wondered how you were getting on with your resourcing.
Lucy, I'm going to get you to answer it, and then Tanya, I'd really like your sort of system overview of it as well. Thank you, Lucy.
Yeah, so I think because we've taken that system oversight, the system has made a positive decision to invest in frailty services. And so obviously when we had our Ageing Well funding, that was all ploughed into hospital at home and so on and so forth. And I think if you look at the sort of staff feedback on the slides, actually shifting people to do proactive care, they kind of realised that a lot of the time they were doing the reactive stuff, and actually if they shifted and did the proactive stuff, they wouldn't be doing the reactive stuff. So again, it's just about changing mindsets, and you've got lots of people out there already, intermediate care, community matrons, the front door frailty service, that actually you can coordinate some of these services in a different way without actually needing more investment to provide this model of care as part of the work that they are doing.
Thank you. And Tanya?
Yeah, I mean, there are different boroughs are trying it different ways. You can try and create a specific resource, and that's helpful. And I think in South East London, we were in a slightly different position to Frimley, in that we already had quite a well-established hospital at home service, which if you don't have is a big gap. But I think, I mean, the approach we're really taking is it's about influencing change amongst existing services in the way that we work, rather than creating massive new teams. We've got the people, we've got the expertise, and it's about how do we use that collective resource more efficiently. And some of that comes down to my comment about we've got lots of cross-cutting skills across different disciplines and different professions, and it's about us maximizing us to our, you know, the limit of our license to, in order to deliver more for the same numbers, and perhaps also accepting slightly less like perfectionisms on an individual level, to say, okay, how do we reach more? And actually doing good for all is better than doing perfect for a smaller group.
I love that. What a fabulous way to end that Q&A. Thank you very much, Tanya and Lucy, for your presentations. And finally, we're going to move on to in fact, it leads on from a couple of questions about can pharmacists refer in, the issue around polypharmacy and the harm that comes from it. So I'm going to ask Nigel Beckett, who is a consultant colleague of mine from Guy's and St Thomas's, and a geriatrician, to talk about multi-morbidity models of care that we have in South East London. Over to you, Nigel.
Thank you very much, Dagny. So yeah, I've held various positions, but I'm now just one of those little jobbing geriatricians who are getting on with things. And what I'm going to try and talk to you a little bit about is a bit of a novel approach. And this is really a very live conversation. And it's about a multi-morbidity model of care project that's ongoing in South East London. And I think I should probably acknowledge that people like Krishna and Robert at a sector level, at the ICB level, are very much driving this. So this is very much about something happening about South East London. And I'm involved really from a Lambeth perspective. And I'm particularly involved because my particular interest is in cardiovascular disease. So next slide. Always nice to start with a quote from someone like Chris Whitty. This is from an editorial from the BMJ from about 5 years ago now. And the concept that we're pretty good at single disease in the NHS, but we're not good when it starts coming to multimorbidity, when you've got conditions coexisting, either in a horizontal or in a vertical integration process. And this was written with the presidents of the Royal College of Primary Care, surgeons, physicians, and we do really need an intellectual shift in how we adopt our research, our training, something that's particularly I'm passionate about in terms of the generalism rather than the specialism that we get so much of. Next slide. So this is quite recent data. This is from only a couple of years old, and is based from looking at NHS data in just short of 4 million individuals and looking over 308 conditions. And what it tells us was what we sort of already know, that first of all, multimorbidity is very common. It doesn't matter whether you talk about multimorbidity as being 2 or more long-term conditions, where we think of it as basic, or more complex when you're thinking about 5 long-term conditions. It is extremely prevalent. It is more prevalent as you get older, and it's going to be very much the future. It's only another 25 years until we're midway through the century, and 84% increase, and about 35 million people in the UK will be considered to be multimorbid. And the greatest increase will be in the most deprived areas. And in terms of cost, if you compare people who are multimorbid against people who are not multimorbid, there's anything from about 1.3 to nearly a 3 times higher cost implication. So the cost burden to the healthcare system, and I include social system in that, is phenomenal. And picking up on the last presentation, 1 in 3 people who turn up to ED have 5 or more long-term health conditions. Now, 10 years ago, it was 1 in 10, and that just gives you a feel for how things have changed. Next slide. So some of the challenges, and we've talked about this. I think first of all, there's the issue is that there aren't going to be clustering of diseases. So my interest is cardiovascular disease, but people who have got CKD, often are diabetic, have heart failure, on top of other aspects as well. But there isn't an overlap of very common problems, such like reduced mobility, chronic pain, isolation, and a real impact on mental health. The problem we have is the system still has a tendency to focus a little bit on individual diseases. We're still too focused on individual diseases when we're talking about some of our training. And I really don't think we have enough generalists in terms of our training. A lot of our drug efficiency are all, again, very much focused on single conditions. And we've touched on this already, that we need a sort of greater service integration, a more holistic approach. And in that conversation, we need an awful lot of more support for mental health. And there is that interplay between psychosocial, socioeconomic, healthcare interplay, which is really important. Someone's mentioned also about polypharmacy. Well, when I first started, you had a myocardial infarction, people were in bed for about 7 or 8 days and you went home. Now you come in and you go from 0 to 5 drugs in the space of about 24 hours. So we have a real impact. And you put all those clustering of diseases, we've got great healthcare for in particular conditions, but you get an awful lot of polypharmacy. I'll come back to a little bit about the research in the conclusion. So next slide. So most of the guidelines, as I've sort of pointed out, is that I've often specific. This is Scottish data. It applies to anywhere in the country. And my particular interest is cardiovascular disease. So if we just click on, you'll find that for those people who have only heart failure, only 3% of patients with heart failure just have heart failure. Next slide. And we're very good at guideline medicine. I sit on NICE guidelines for cardiovascular disease, and we're very good at sort of hypertension, lipids, or whatever. But as you get to more long-term conditions or people who are living with frailty, we have to move a little bit away from guideline medicine. It's not going to give us the answer. And we need to be thinking more about care and support planning. Next slide. I think the final point I'd say in this introductory little bit is that multimorbidity is not frailty. On the left of the slide, you've got Swedish data actually from the King Sholem healthy aging study. And what you can see is they've clustered together certain diseases, and the levels of frailty does vary between different types of multimorbidity. And on the right-hand side, you've got the prevalence. And what you can see is multimorbidity is very prevalent from the ages of 60, with frailty increasing as you get older. So multimorbidity is associated with frailty, but it's not the same. Next slide. So I think people will know about the report from Claire Fuller, and was into the development of integrated neighbourhood teams. And this is where, in South East London, this the idea of actually having a multimorbidity project sort of developed from, really sort of focusing on that sort of those core issues in terms of having an integrated patient-centric, holistic, and just to pick up on Tanya's point as well about the importance of prevention, and also utilizing the diverse skills. One of the biggest issues is also reaching those who are difficult to reach, and there's an awful lot of social inequality within that. Next slide. So this is the multimorbidity model that we are testing. And as I said, it's a very live process that's ongoing at the moment. And it falls into 3 sort of categories, really about trying to get improved patient experience. Now, we're focusing very much on CKD, but we've chosen CKD was chosen because it's a little bit more easier to identify, and we can use that as a model to see if we can then expand it to other areas. The bit I'm talking about is probably those who are just on the multimorbid, but we do actually have frailty aspects, and we have geriatricians associated with advanced kidney clinics, both at King's and at Guy's, which is something new. We're looking at ways of improved working because we can't carry on doing the same things as we are. We've got to come up with new ways of doing things. If you've got your CKD, diabetes, and heart failure, you might get to a heart failure clinic, a CKD clinic. You might come and see me for your hypertension. You're so in a geriatrician as well. It's just mad. So all that leads to trying to increase the efficiencies across the whole of the process. Next slide. So the project's running across all 6 boroughs in South East London. As I said, I'm involved on the Lambeth side. A lot of time and effort went into developing the design and how we would run over a course of workshops involving all the boroughs and representation. The representation was very broad to get engagement. And we also had a secondary care group, really just as a touch point to oversee that liaison, because part of this is about trying to develop new ways of working between primary and secondary care. Next slide. So this is what we're doing within in Lambeth. We've version 2.6 of our SOP, which just goes to show you it's a very iterative process in terms of continuing to develop and remodel how we do things. One of the main aspects is trying to identify patients with CKD, and one of the fundamental first stumbling blocks was getting over the coding and the coding issues within primary care, which was a challenge. And then from having identified those with CKD, we look to see if there are people who are falling into ones who need a little bit more specialist care. We've got MDMs going. Next slide. One of the key components of this, though, is actually having the care coordinators in primary care. So they get information that we do centrally within the primary care network. We send the practices a list of people who we think might have CKD, and they can then reach out to them. We've set up a whole new system, but it's using the people who are already there. It's just a different way of operating. So we now actually have a single point of access for myself, a renal physician, a cardiologist and diabetologist in terms of advice and guidance. And the idea is trying to prevent need for hospitalization. It also helps in terms of cross-fertilization of education and aspects. And on top of that, we now have, and as I said, as you can see, these are the dates, a very live process in terms of a multidisciplinary meeting between ourselves in primary care and primary care colleagues and ourselves in secondary care. Next slide. So this is very fresh. This is some of our latest information. We're a long way from actually we're probably a few months off from actually finishing the project and then going towards analysis. So this is very live, very raw data for you, and some of my thoughts. So first of all, I think one of the things was about case finding. It was really important to try and getting all that coding right. And in fact, from the start of the project in April to December in Lambeth, we have identified 596 new CKD 3 or above cases of which actually, if you look down the slide, has had a real prevalent impact on the prevalence. We knew the prevalence of CKD was probably lower than it was the national average in South East London, and it does vary from practice to practice. So take on the Clapham PCN, we've gone from 2 to 2.7% for our CKD prevalence. That's a 25% increase from just getting the coding right. And once you've got the identification, then you can maybe start thinking about intervention, maintaining and making a difference. So just going back up the slide, the coding and coding correction, because there are some people who are coded incorrectly, that they've got CKD, but they don't. If there was a one-off acute kidney injury episode, they don't actually have CKD. So trying to get the coding right is a real primary step. I've talked about upskilling. We've upskilling the care coordinators. We're looking at that in terms of supporting from primary care, secondary care, running training programs for that. And also in terms of, to some extent, there's a little bit of hand-holding. I'd also probably say that I've learned an awful lot myself from my renal and diabetic colleagues as well. So as well as cross-fertilization between ourselves and primary care, I think there's cross-fertilization within primary care and within secondary care. There's certainly been a much greater focus now on CKD, and there's an awful lot more team collaboration, a real multidisciplinary teamwork. And I think the integration is beginning to improve an awful lot in terms of developing those relationships between primary and secondary care. Moving on. Next slide. So this is some of the, this is only about a month old. We just did a staff feedback. And the good thing is, as well as getting very positives, we've also got sort of positive, we got useful feedback in terms of things perhaps we can improve on. So this, as I said, it's a very iterative process. But the general feeling is that we're moving in the right direction. Next slide. I'm going to give you some take-home messages. No. So this has been a real whistle-stop tour. Multimorbidity, it is challenging. We've been talking about frailty, but multimorbidity is challenging. It's challenging to health and social care professionals. It's challenging to the patients. It's challenging to the carers in terms of trying to balance up all the different systems. You do, without a shadow of a doubt, need a holistic professional approach. And then without that, we're not going to be able to address the issues. I'm going to bang my drum again. I do think we need a generalist approach a lot of the time. And we do have a little bit of over-specialization. But we do need a different system-wide integrated approach. And I think the final comment I'd make is that if you look at the trials for intervention, often some of the trials for intervention don't show benefit. But if you look at the observational trials, they do show benefit. And I think that's one of the important key aspects, is not to give up too soon when you're changing something, because it's all about relationships and you need to embed those relationships, and those relationships take time to develop. So very whistle-stop tour, so thank you very much.
Thank you, Nigel. Unfortunately, we don't have much time for questions, but I do just want to tie together what we've heard. Jagdeep, thank you for your bit around really the importance of stratification, segmentation, the importance of population health data, preventing frailty and preventing crisis in frail patients. We then moved on to Tanya's importance of pulling all the actors and the players together. And I think we have been lucky in South East London with the historical interest in this area. So aging well and the strategy around that, really key. And then the implementation, Lucy, of what you've managed to do in Frimley in a focused model is really helpful. What is absolutely key is showing the cost benefit of that, because I think that's going to become increasingly important over the next few weeks. Multimorbidity, those were beautiful slides, Nigel, and a really interesting use of the CKD model. But I suppose what we have demonstrated here is just around frailty and flow, and some of our most frequent flyers of our unscheduled care services and our scheduled care elective services. We are hitting all of the 3 shifts, so analog to digital, hospital to home, and treatment to prevention. We also are improving the primary and secondary care interface, which is another focus at the moment nationally, and then just improving and strengthening the integrated neighbourhood teams, who I think I can, with a degree of confidence, say I think will survive whatever else is tumultuous at the moment in our context. So a very, very, from my side, my gratitude, and all of you've joined. We had just under 100 people at one point. To all the speakers, Jagdeep, Tanya, Lucy and Nigel, thank you very much. And I'll let John finally close. Thank you.
Oh, Dagny, I mean, it's the Cheltenham Festival at the moment. I don't think any of the runners there have galloped quite as powerfully as our speakers today have gone through their presentations. That was simply sensational. I mean, I came on as a non-clinician, didn't really know a huge amount about the whole landscape and local level solutions. You've completely opened my eyes. Thank you to everybody concerned. Really appreciate it. Can I also have a big shout out to the people behind the scenes who've made all of the transition of slides possible and so on. That would be Jade and so on as well. Really appreciate it. Let's do another one of these again on a different topic. That was fabulous. Thank you very much, everybody.
Thank you, John, and enjoy your rest of your afternoon, everyone. Bye-bye.
Thank you. Thank you.
Thank you.